بسم الله الرحمن الرحيم. الحمد لله رب العالمين، والصلاة والسلام على أشرف الخلق سيدنا محمد. هنتكلم عن drugs and pregnancy. The duration of pregnancy is approximately 280 days, measured from the first day of the last menstrual period of birth. Pregnancy is counted from the first day of the woman's last period, not the date of conception, which generally occur 2 weeks later. يعني أنا لو حسبت بداية من الconception هتبقى 2 weeks after the first day of the last period. Preterm or premature baby أو neonate is delivered before 37 weeks. Term from 37 to less than 42 weeks, and post-term after 42 weeks. Pregnancy is divided into 3 periods of 3 calendar months, trimester, and first trimester, second trimester, and third trimester. Drug absorption during pregnancy may be altered by delayed gastric emptying and vomiting. Increased gastric pH may affect absorption of weak acidic and basic drugs. Hepatic perfusion increase, and the fact the drugs have a high extraction ratio. Higher estrogen and progesterone levels may alter liver enzyme activity and increase elimination of some drugs, but cause accumulation of others. Maternal plasma volume, cardiac output, and glomerular filtration increase by 30% to 50% or higher during pregnancy, possibly lowering the plasma concentration of renally cleared drug. Body fat increases, thus volume of distribution of fat-soluble drugs may increase. Plasma albumin concentration decrease, thus volume of distribution of highly protein-bound drugs may increase. However, there may be little change in serum concentration as these unbound drugs are more rapidly cleared by the liver and kidney. ده summary للpregnancy associated changes in pharmacokinetic parameter and consequences. Drugs that pass through the placenta. Drugs with molecular weight less than 500 Dalton transfer readily. Drug with molecular weight from 600 to 1000 Dalton cross more slowly. Drugs with molecular weight greater than 100 Dalton, as insulin and heparin, don't cross insignificant amounts. Lipophilic drugs, as opioids and certain antibiotics, cross more readily than do water-soluble drugs. Certain protein-bound drugs may achieve higher plasma concentration in the fetus than in the mother. Drug selection during pregnancy. The incidence of congenital malformation is approximately 3 to 5%, and it is estimated that 1% of all birth defects are caused by medication exposure. Adverse effects on the fetus depend on drug dose, route of administration, concomitant exposure to other agents, and the stage of pregnancy when the exposure occurred. Fetal exposure to a teratogen in the first 2 weeks after conception may have an all or nothing effect. It could destroy the embryo or have no ill effect. Exposure during organogenesis from 18 to 60 days post-conception may cause structural anomalies as methotrexate, cyclophosphamide, diacylstilbestrol, lithium, retinoid, thalidomide, some anti-epileptic drugs, and coumarin derivatives. In the late 1950s and early 1960s, The drug thalidomide causes an estimated 10,000 birth defects and thousands of fetal deaths worldwide. The affected babies typically suffered from phacomelia, a failure of the limbs to develop. These unfortunate children were cruelly referred to as flipper babies. Thalidomide had been prescribed to pregnant women to help reduce morning sickness, but tragically, it turned out to be toxic to developing fetus. After this point may result in gross retardation, central nervous system, or other abnormalities or death. Non-steroidal anti-inflammatory drugs and tetracycline derivatives are more likely to exhibit effects in the second or third trimester. Principles for drug use during pregnancy include selecting drugs that have been used safely for a long time, prescribing doses at the lower end of the dosing range, eliminating non-essential medication and discouraging self-medication, avoiding medication known to be harmful. Preconception planning. Folic acid supplementation between 0.4 and 0.9 mg daily is recommended throughout the reproductive year to reduce the risk for neural tube defect in offspring. Women at high risk, as those who take certain seizure medication or who have had previously affected pregnancy, should take 4 mg per day. Between the 17th and 30th day after conception, or 4 to 6 weeks after the first day of a woman's last menstrual period, the neural tube forms in the embryo and then closes. The neural tube later becomes the baby's spinal cord, spine, brain, and skull. Some issues influenced by pregnancy: gastrointestinal tract, constipation, commonly occur during pregnancy. To treat constipation, physical exercise and increase intake of dietary fiber and fluid. If additional therapy is warranted, give supplemental fiber and or stool softener. Polyethylene glycol, lactulose, sorbitol, magnesium and sodium salts can be used intermittently short term. Senna and bisacodyl can be used occasionally. Avoid castor oil and mineral oil. Mineral oils should not be used during pregnancy because they reduce nutrient absorption. Castor oil can cause the uterus to contract. It is not recommended during pregnancy. Therapy for gastroesophageal reflux disease include lifestyle and dietary modification, for example, small frequent meal, avoid alcohol, tobacco and caffeine, avoid food 3 hours before bedtime, elevate the head of the bed. If necessary, initiate aluminum, calcium or magnesium antacid, sucralfate or cimetidine or ranitidine. Proton pump inhibitor are option if response to histamine or H2 receptor blocker is insufficient. Avoid sodium bicarbonate and magnesium trisilicate. Therapy for hemorrhoids includes high intake of dietary fiber, adequate oral fluid intake, use of SIDS baths. If response is inadequate, laxative and stool softener can be used. Topical anesthetic, skin protectant, and astringent may help irritation and pain. Topical hydrocortisone may reduce inflammation and pruritus. Nausea and vomiting. Non-pharmacological treatment include eating small, frequent meals, avoid fatty foods, acupressure. Pharmacotherapy may include antihistaminic as doxylamine, pyridoxine, dopamine antagonist as metoclopramide. Ondansetron can be used when other agents have failed. Ginger is considered safe and effective. Dexamethasone and prednisolone have been effective for hyperemesis gravidarum. Gestational diabetes mellitus. First-line therapy for all women with gestational diabetes mellitus include dietary modification and caloric restriction for obese women. Daily self-monitoring blood glucose is required. If nutritional intervention failed to achieve fasting plasma glucose level of less than 90 to 99 mg per deciliter, 1 hour postprandial plasma glucose concentration of 140 mg per deciliter or less, 2 hour postprandial level of less than 120 to 127 mg per deciliter. So, therapy with recombinant human insulin should be instituted. Glyburide may be considered as an alternative. Metformin may also be considered, but it crosses the placenta and is less studied. Hypertension. Hypertension during pregnancy include gestational hypertension, hypertension without proteinuria developing after 20 weeks gestation, preeclampsia, hypertension with proteinuria, chronic hypertension, pre-existing hypertension, or developing before 20 weeks gestation, and preeclampsia superimposed on chronic hypertension. Hypertension in pregnancy is diastolic blood pressure of 90 mm mercury or more, based on the average of 2 or more measurements from the same arm. For women at risk for preeclampsia, low dose aspirin 75 to 81 mg per day after 12-week gestation reduce the risk of preeclampsia by 17%. Aspirin also reduces the risk of preterm birth by 8% and fetal and neonatal deaths by 14%. Calcium 1 to 2 grams per day decreases the relative risk of hypertension by 30% and preeclampsia by 48%. Calcium 1 gram per day is appropriate for all pregnant women. Antihypertensive drug therapy is discussed later under chronic illness in pregnancy. Magnesium sulfate is used to decrease the risk of progression of preeclampsia to eclampsia and to treat eclamptic seizure. Avoid diazepam and phenytoin. Venous thromboembolism. For treatment of acute thromboembolism during pregnancy, low molecular weight heparin is preferred over unfractionated heparin. Low molecular weight heparin offers advantages over conventional unfractionated heparin, including a more predictable anticoagulant effect, no need for monitoring of anticoagulation, resistant to inhibition by activated platelets, and a lower incidence of heparin-induced thrombocytopenia. Continue treatment throughout pregnancy and for 6 weeks after delivery. Duration of therapy should not be less than 3 months. Avoid warfarin because it may cause fetal bleeding, malformations of the nose, stippled epiphysis, or CNS anomalies. Acute care issues in pregnancy. Headache. For tension and migraine headache during pregnancy, first-line therapies are no pharmacological, including relaxation, stress management, and biofeedback. For tension headache, acetaminophen or ibuprofen can be used if necessary. All NSAIDs are contraindicated in the 3rd trimester because of the potential for closure of the ductus arteriosus. What is the ductus arteriosus? The ductus arteriosus is a blood vessel that connects the pulmonary artery and the aorta. In the fetus, it enables blood to bypass the lung. The fetus does not breathe air, and thus blood does not need to pass through the lung to be oxygenated. After birth, blood needs to be oxygenated in the lung, and normally the ductus arteriosus closed quickly, usually within a day up to 2 weeks. If the connection remains open, the abnormal opening causes too much blood to circulate to the baby's lung and heart. Untreated, the blood pressure in the kidney, lung might increase, pulmonary hypertension, and the baby's heart might enlarge and weaken. Avoid aspirin in the third trimester, as it may also cause closure of the ductus arteriosus, maternal and fetal bleeding, and decrease uterine contractility. Opioids are rarely used. For migraine headache, acetaminophen and ibuprofen can be used. Opioids have been used, but they can contribute to nausea, and long-term use can cause neonatal withdrawal. For non-responsive migraine, sumatriptan can be used. Ergotamine and hydroergotamine are contraindicated. For migraine-associated nausea, promethazine, prochlorperazine, and metoclopramide can be used. For pregnant women with severe headaches, usual migraine, not responsive to other treatment, propranolol at the lowest effective dose can be used as a preventive treatment. Alternatives include amitriptyline or nortriptyline 10 to 25 mg daily by mouth. Urinary tract infection. The principal infecting organism is E. coli, but the Proteus mirabilis, Klebsiella pneumonia, and group B Streptococcus cause some infection. Untreated bacteriuria may result in pyelonephritis, preterm labor, preeclampsia, transient renal failure, and low birth weight. Treatment of asymptomatic bacteriuria is necessary to reduce the risk of pyelonephritis and premature delivery. Treatment for 7 to 14 days is common. Repeat urine culture are recommended monthly for the remainder of gestation. Cephalexin is considered safe and effective for asymptomatic bacteriuria. E. coli resistant to ampicillin and amoxicillin is problematic. Nitrofurantoin is not active against Proteus and should not be used after week 37 due to concern for hemolytic anemia in the newborn. Sulfur-containing drugs may increase the risk for kernicterus in the newborn and should be avoided during the last weeks of gestation. Folate antagonists such as trimethoprim are relatively contraindicated during the first trimester because of their association with cardiovascular malformation. Regionally, increased rates of E. coli resistant to trimethoprim sulfa limit its use. Fluoroquinolone and tetracycline are contraindicated. Sexually transmitted disease. Complications of chlamydia trachomatis include pelvic inflammatory disease, ectopic pregnancy, and infertility. Chlamydia infection can be transmitted at birth to the neonate and cause conjunctivitis and a subacute afebrile pneumonia. Penicillin is the drug of choice for syphilis, and it is effective for preventing transmission to the fetus and treating the already infected fetus. Neisseria gonorrhoeae is a risk factor for pelvic inflammatory disease and preterm delivery. Symptoms in the neonate as rhinitis, vaginitis, urethritis, ophthalmia neonatorium, and sepsis usually start within 2 to 5 days of birth. Blindness can occur. The overriding concern with genital herpes is transmission of the virus to the neonate during birth. Maternal use of acyclovir during the first trimester is not associated with an increased risk of birth defects. Valacyclovir is an alternative. Famciclovir safety data are more limited. Bacterial vaginosis is a risk factor for premature rupture of membranes, preterm labor, preterm birth, intraamniotic infection, and postpartum endometriosis. Data are conflicting concerning treating women at low risk for preterm labor. Chronic illnesses in pregnancy, allergic rhinitis and asthma. Diagnosis and staging of asthma during pregnancy is the same as in non-pregnant women, but more frequent follow-up is necessary. The risks of medication used to the fetus are lower than the risks of untreated asthma. Treatment follows a 6-step approach. As step 1, all pregnant patients with asthma should have access to a short-acting inhaled beta-2 agonist. Albuterol is the preferred agent. For persistent asthma, step 2 or higher, low, medium, or high doses of control corticosteroids are functional. Budesonide is preferred, but corticosteroids used before pregnancy can be continued. Long-acting beta-2 agonists are safe. Cromolyn, leukotriene receptor antagonist, and theophylline are considered alternative agents, but they are not preferred. For patients with the most severe diseases, systemic corticosteroids are recommended. Allergic rhinitis. First-line medication for allergic rhinitis during pregnancy include intranasal corticosteroids, nasal cromolyn, and first-generation antihistaminics. Intranasal corticosteroids are the most effective treatment and have a low risk for systemic effect. Beclomethasone and budesonide have been used most. Loratadine and cetirizine don't appear to increase fetal risk, but they have not been extensively studied. Use of an external nasal dilator, short-term topical oxymetazoline, or inhaled corticosteroids may be preferred over oral decongestant, especially during early pregnancy. Diabetes. Insulin is the drug of choice for patients with type 1 or type 2 diabetes during pregnancy. Switch 1. Receiving insulin glargine or Datmir to NPH insulin. Glyburide and metformin may be alternative but are not recommended by the American Diabetic Association. Goals for self-monitoring of blood glucose are the same as for GDM. Epilepsy. Major malformations are 2 to 3 times more likely in children born to women taking anti-epileptic drugs than to those who do not. But the risks of untreated epilepsy to the fetus are considered to be greater than those associated with the anti-epileptic drugs. Major malformations with valproic acid therapy are dose-related and range from 6.2 to 10.7%. When possible, avoid valproic acid during pregnancy to minimize the risk of neural tube defect, facial cleft, and cognitive teratogenicity. Rates of major malformation associated with monotherapy of other anti-epileptic drugs are 2.9 to 3.6%. Polytherapy is associated with higher rates. Carbamazepine and lamotrigine may be the safest anti-epileptic drugs for use in pregnancy. Phenytoin, lamotrigine, and carbamazepine may cause cleft palate, and phenobarbital may cause cardiac malformation. Drug therapy should be optimized prior to conception, and anti-epileptic drug monotherapy is recommended when possible. If a drug withdrawal is planned, it should be done at least 6 months prior to conception. All women with epilepsy should take folic acid 4 to 5 mg daily, starting before pregnancy and continuing through at least the first trimester. The American Academy of Pediatrics recommends that all neonates receive vitamin K at delivery. Hypertension. Severe hypertension, systolic blood pressure equal or more than 160 mm mercury, or diastolic blood pressure equal or more than 110 mm mercury, can cause maternal complication, hospital admission, and potential premature delivery. Drug therapy is indicated for women with blood pressure of 160 over 110 mm mercury or more. Blood pressure should be lowered by a maximum of 25% in the first minute to 1 hour, with further reduction to below 160 over 100 mm mercury over a period of hours. Commonly used agents are lipitlol and hydralazine, but hydralazine causes more fetal adverse effect. Oral nifedipine may also be used. Treatment of non-severe hypertension, systolic blood pressure 140 to 159 mm mercury, or diastolic blood pressure 90 to 109 mm mercury, reduces the risk of severe hypertension by 50%, but does not substantially affect fetal outcomes. In the United States, treatment is started at a blood pressure of 150 to 160 over 100 to 110 mm mercury, with a goal of blood pressure of less than 150 over 100 mm mercury. No evidence exists for the superior efficacy of one antihypertensive agent versus another, but the drugs commonly used include lipitlol, methyl-dopa, and calcium channel blockers. Beta antagonists can be used except atenolol. ACE inhibitors, angiotensin receptor antagonists, and renin inhibitors are contraindicated throughout pregnancy. Thiazide diuretics can be used in women who were treated with them before pregnancy. Depression. In general, monotherapy is preferred over polytherapy, even if higher doses are required. If antidepressants are used, the lowest possible dose should be used for the shortest period of time to minimize adverse fetal and maternal pregnancy outcome. In one study, pregnant women who stopped taking antidepressants were more likely to relapse than women who completed treatment. The selective serotonin reuptake inhibitors are not considered major teratogens. The serotonin norepinephrine reuptake inhibitors are less well defined. Use of selective serotonin reuptake inhibitors and serotonin norepinephrine reuptake inhibitor in the later part of pregnancy is associated with persistent pulmonary hypertension of the newborn. Tricyclic antidepressants are not considered major teratogen, but have been associated with neonatal withdrawal syndrome when used late in pregnancy. An epidemiologic study suggests that first trimester use of paroxetine may be associated with a 1.5 to 2-fold increased risk for cardiac defect in the infant. Thyroid disorder. For thyroidism, give levothyroxine to attain a thyroid-stimulating hormone of 0.1 to 2.5, 0.2 to 3, and 0.3 to 3 milli international unit per liter in the first, second, and third trimester respectively. It can be started at 0.1 milligram per day. Women receiving thyroid replacement therapy before pregnancy may require increased dose during pregnancy. Monitor thyroid stimulating hormone every 4 weeks during the first half of pregnancy and at least once between 26 and 32 weeks of pregnancy to allow for dose titration. Hypothyroidism. Hypothyroidism therapy include the thiamides, mesamazole, propylthiouracil. Dose reduction are possible after attaining a thyroid state to maintain the normal function of thyroid gland. Some support a switch to propylthiouracil during the first trimester because of the potential risk with mesamazole, followed by a subsequent switch to mesamazole for the second and third trimester to prevent hepatotoxicity from propyl thyroid. Iodine 131 is contraindicated. The goal of therapy is to attain free thyroxine concentration near the upper limit of normal. Labor and delivery. Preterm labor. Preterm labor is labor that occurs between 20 and 37 weeks of gestation. Tocolytic therapy. The goals of tocolytic therapy are to postpone delivery long enough, to allow for maximum effect of antenatal steroids, for transportation of the mother to a facility occupied to deal with high-risk deliveries, to prolong pregnancy when there are underlying self-limited conditions that can cause labor. Tocolytics can be started when there are regular uterine contraction with cervical chain. Don't use them in cases of intrauterine fetal demise, a lethal fetal anomaly, intrauterine infection, fetal distress, severe preeclampsia, vaginal bleeding, or maternal hemodynamic instability. There are 4 classes of tocolytics: beta agonist, magnesium sulfate, NSAID, calcium channel blockers. Prolongation of pregnancy with tocolytic is not associated with significant reduction in rates of respiratory distress syndrome or neonatal death. Beta agonists have a high risk for maternal side effects. Terbutaline doses range from 250 to 500 micrograms subcutaneously every 3 to 4 hours. The FDA cautions that injectable terbutaline should not be used to prevent preterm labor or treat it behind 48 to 72 hours because of the risk for maternal death and heart problems, including cardiac arrhythmia, myocardial infarction, pulmonary edema, and tachycardia. Don't use oral terbutaline for the prevention or treatment of preterm labor, as it has the same risks as the injectable form, but has not been shown to be effective. Nifedipine is associated with fewer side effects than magnesium or beta agonist. 5 to 10 mg nifedipine may be administered sublingually every 15 to 20 minutes for 3 doses. Once stabilized, 10 to 20 mg may be administered orally every 4 to 6 hours for preterm contraction. It can cause hypotension and a change in uteroplacental blood flow. Indomethacin 50 to 100 mg orally or rectally, followed by 25 to 50 mg orally every 6 hours, has been used. Premature constriction of the ductus arteriosus has been reported. Antenatal glucocorticoids. A Cochrane review shows the benefit of antenatal corticosteroids for fetal lung maturation to prevent respiratory distress syndrome, intraventricular hemorrhage, and death in infants delivered prematurely. Current recommendations are betamethasone 12 mg intramuscular every 24 hours for 2 doses, or dexamethasone 6 mg intramuscular every 12 hours for 4 doses. To pregnant women between 26 and 34 weeks gestation who are at risk for preterm delivery within the next 7 days. Benefits from antenatal glucocorticoids administration are believed to begin within 24 hours. Group B streptococcus infection. Prenatal screening, vaginal and rectal culture for Group B streptococcus colonization of all pregnant women at 35 to 37 weeks gestation is recommended. If cultures are positive, or if the woman had a previous infant with invasive Group B streptococcus disease, or if the woman had Group B streptococcus bacteriuria, antibiotics are given. The currently recommended regimen for Group B streptococcus disease is penicillin G, 5 million units intravenous, followed by 2.5 million units intravenous every 4 hours until delivery. Alternatives include ampicillin, 2 gram intravenous followed by 1 gram intravenous every 4 hours, cefazolin, 2 gram intravenous followed by 1 gram every 8 hours, clindamycin, 900 mg intravenous every 8 hours, erythromycin, 500 mg intravenous every 6 hours. and penicillin allergic in whom sensitivity testing show resistance to clindamycin and erythromycin. Vancomycin 1 gram intravenous every 12 hours until delivery can be used. Cervical ripening and labor induction. Prostaglandin E2 analogous, e.g. dinoprostone, Pibidil gel and Cervidil vaginal insert are commonly used for cervical ripening. Fetal heart rate monitoring is required when Cervidil is used. Misoprostol, a prostaglandin E1 analogous, is effective and expensive, but it has been associated with uterine rupture. Oxytocin is the most commonly used agent for labor induction after cervical ripening. Labor analgesia. The intravenous or intramuscular administration of narcotics is commonly used for pain associated with labor. Compared with epidural analgesia, parenteral opioids are associated with lower rates of oxytocin augmentation, shorter stages of labor, and fewer instrumental deliveries. Epidural analgesia involve administering an opioid and/or anesthetic as fentanyl and/or bupivacaine through a catheter into the epidural space to provide pain relief. Epidural analgesia is associated with longer stage of labor, more instrumental deliveries, and maternal fever compared to parenteral narcotic analgesia. Patient-controlled epidural analgesia results in a lower total dose for local anesthetic. Complications of epidural analgesia include hypotension, nausea, vomiting, itching, and urinary retention. Other options for labor analgesia include spinal analgesia and nerve blocks. Lactation issues. Drug use during lactation. Medication enter breast milk via passive diffusion of non-ionized and non-protein bound medication. Drugs with high molecular weight, lower lipid solubility, higher protein binding are less likely to cross into breast milk, or they transfer more slowly or in a smaller amount. The higher the maternal serum concentration of drug, the higher the concentration will be in breast milk. Drugs with longer half-life are more likely to maintain higher levels in breast milk. The timing and frequency of feedings and the amount of milk ingested by the infant are also important. Strategies for reducing infant risk from drugs transferred into breast milk include selecting medication for the mother that would be considered safe for use in the infants and choosing medication with shorter half-lives, higher protein binding, lower bioavailability, and lower lipid solubility. Relactation or restarting breastfeeding after a gap. For relactation, use metoclopramide 10 mg 3 times daily for 7 to 14 days only if non-drug therapy is ineffective.